on compliance with the HCBS settings final rule. Not sure if you heard all of this part, but early on when we gave the first webinar, we gave you an overview of some of the things that we found in conducting the site assessment and some of the issues that may need to be worked on through the remediation process. And so today we're going to talk through that a little bit more in depth and connect those findings to some strategies for how to achieve compliance. I'll go ahead and turn it over to the Mississippi Department of Mental Health to do some introductions, and then we'll get started from there.
Awesome. Good morning. This is Jennifer Fulcher with Bureau of Intellectual Disabilities. And here with us today we have
I'm Betty Pinion, Pamela Harkin,
Matthew Gordon,
Monica Wilmer, Faye Foster,
Jerry Lewis, Philip Garrison,
Deborah Edstall, Renee Brett.
well, thank you guys for joining us. Like Amanda said, this is our fourth and final webinar, so we encourage you to ask questions and that you have. This is the time to do it. If you have questions, then we want to know. So feel free to fully participate in this webinar, and I'm going to turn it back over.
Thanks, Jennifer. We'll go ahead and introduce the team from Public Consulting Group that's on, and then I'll turn it over to Jamie to give you some instructions on how to ask questions and make sure that you're engaged throughout the process. But this is Amanda Alvey. I am a senior consultant with Public Consulting Group. We also have Kathy on the line. Kathy, do you want to introduce yourself, please? All right, we may be having audio issues with Kathy. Jamie, can you introduce yourself, please?
Yeah, hi everyone, I'm Jamie Cohen and I'm also with Public Consulting Group.
On the line is Kathy Anderson. She is a senior advisor with Public Consulting Group. So you've heard us, if you've joined other webinars, you've heard us speak quite a few times. So we will all be on today and here to address any questions that you may have as we walk through this. Jamie is going to go ahead and give us an overview of the agenda, and we'll get started.
Great, thanks, Amanda. So before we go through the agenda, I just want to go over some logistics for this webinar. We really want this to be engaging, and we want you to ask questions throughout. So please use the chat function, and also please keep yourselves muted. I can hear some background noise right now. I'll do my best to keep everyone on mute. You should be on mute upon entry. Unfortunately, it's not locked, so please keep yourselves on mute. So please use the chat function if you have any questions. And we also have polls incorporated throughout the webinar. So I will send everyone in the chat box right now the website you can go to. I will send everyone the website you can go to participate in the poll. We have a few throughout. You can either participate by the website, or you can also do it through your phone. You can text my name 341 to a number. So I will send both of those options into the chat function so that everyone can participate throughout this webinar. And if you are having any technical assistance issues, so if you are having audio issues or you want to send a message privately, you can also do that through the chat function. You can either send a message out to everyone, or you can send it directly to Jamie Cohen. That's me, and I'm the host for the webinar. Okay, and now for the agenda. So first we're going to give an overview of the HCBS settings final rule, and then we're going to be going into some more information about person-centered practices. And then, as Amanda mentioned earlier, we'll be diving deeper into some findings from Mississippi, and then we'll complement that with strategies that Mississippi can use moving forward. And then we'll talk through next steps with remediation, the heightened scrutiny process, and again, just next steps moving forward. And then we'll have an opportunity at the end for any questions. But like I said earlier, if you have questions throughout the webinar, please send those through the chat function so that we can address them throughout. Okay, so for our first webinar, we're going to ask, we want to really know who's in the webinar and what your positions are. So the first question is, which position best describes you in your provider agency? So in order to participate, you can respond at pollev.com/JamieCohen341. You can also text Jamie Cohen 341 to this number here, 22333. And I will send those instructions into the chat box as well. All right, so it looks like we have some directors, administrative staff, support coordinators, direct support staff, and then we have other as well. I'll let this run for another 10 seconds or so. Okay, great. And again, we just wanted to do this to get a feel for who's in the webinar since we're not in person. This just gives us some background information about who you all are and where you're coming from. So thank you for participating in the first poll.
All right.
Now,
we'll have a couple more of
I'll turn
those
it back over
kind
to
of
you.
throughout as we go. Thank you, Jamie. So yeah, definitely appreciate your responses there, and encourage you to continue participation both through the poll functions and as we start providing information. We will stop throughout the presentation to address any questions that come in the chat box. So definitely can't encourage you enough to feel free to, even if it's just comments, if you have ideas or strategies for best practices as we go along, feel free to share those as well. And just one more reminder, if you are not on mute, please keep yourself muted, and we will have those opportunities to engage throughout the process. We'll start with an overview of the HCBS settings final rule. I know you all have heard this 1,000 times, but we really want to make sure that we're starting with why we're all here and why we're doing what we're doing. And this really is the foundation for all of the work that's being presented. We know that the scope of the HCBS settings final rule is to ensure that individuals receiving services through home and community-based services programs have full access to the benefits of community living. The whole spirit and intent of the regulation was to ensure that individuals receiving those waiver services have the same opportunities. They should be able to access their community and live their daily lives just as anybody else in the broader community that is not receiving Medicaid services. The final rule also reinforced some things that were already in place between the Americans with Disabilities Act, the Supreme Court decision in Olmstead, and person-centered planning requirements in particular. Those were not new principles. They weren't anything that had been unheard of in the HCBS world, but what the final rule did was really put it into place and encourage states to make sure that they were following those guidelines as they're implementing these HCBS programs. So that really is the foundation and the emphasis for why we're doing what we're doing. As the rule highlighted, there are 5 main characteristics that you should see in every home and community-based setting. JB, if you could flip this slide, please. So what that regulation says is that for a setting to truly be home and community-based, these are the characteristics that should be present. The one that we've talked about most recently in particular is integration and access to the broader community. So again, individuals, ensuring that they're not isolated or being treated as if they're institutionalized, but really being members of that broader community just like you or I would be. The second characteristic is that where the individual lives or attends their day program should be selected by that individual from settings options. Those options should include settings that are not just specific to individuals with disabilities. If they're choosing their home, it should be, if they're choosing an apartment or a home to live, it should be in the community, and they should be able to choose to live among other individuals that are not receiving services, if that's what their choice is. The third characteristic is ensuring individual rights of privacy, dignity, and respect, freedom from coercion, and the use of restraints. So those are things that we will definitely touch on more in depth as we walk through some of the findings from the site assessment and providing some strategies for how to make sure that those rights are preserved for each individual in your setting. The fourth characteristic is optimizing autonomy and independence in making life choices. So again, the whole spirit of the rule is based on an individual's choice and how they choose to live their life, from the meals that they eat to where they live to the activities that they want to engage in on a daily basis. And the fifth characteristic for all HCBS settings is that the setting is facilitating choice regarding services and supports and who provides them. So again, making sure that individuals can choose paid and unpaid supports, what services they receive, whether those services are received on site or they have access to services in the broader community. The regulation also put forth some additional characteristics for provider-owned or controlled residential settings. Those are also some things that we'll walk through on the residential side, but ensuring that each individual has a lease or other legally enforceable agreement in place. It may not be termed as a lease, but should function essentially the same way and make sure that individuals have the same protections from eviction and rights to live where they choose to live, just like anybody else would that is leasing a home or an apartment. Individuals should also have privacy in their sleeping or dwelling unit. That includes lockable doors, choice of roommates, choice of housemates, and how they choose to furnish and decorate where they sleep and where they live. Individuals should have opportunities to control his or her own schedule. That includes access to food at any time. Individuals should have choices in visitors and who can visit and when they can visit. And most importantly, the setting should be physically accessible. Even though in the regulation, physical accessibility is mentioned specifically as a characteristic for provider-owned or controlled residential settings, that is a characteristic that CMS has said really applies to all settings. If you're serving individuals with disabilities, there's some other regulations and assurances in place that you have to follow to make sure that that setting is physically accessible to those that are receiving services. We'll go ahead and flip to our next poll. So before we take a deeper dive, we really just wanted to get a gauge from you all. As Jennifer mentioned, this is our fourth webinar. At this point, what do you feel would be some additional resources that your site or agency may need in order to effectively complete remediation and achieve compliance? And we have a few options here, whether that's additional education, training, resources, anything else that you can think of that's not listed here, or if you feel that you do not need any additional resources. We would love to hear from you here, and this will also help guide our work and working with DMH as we move forward through the remediation process to see where we may need to target some additional assistance. And feel free as you're responding If there are particular areas of training or particular resources that you have in mind, feel free to drop those in the chat box as well. All right. Kind of what we expected, definitely a lot of training and resources, education. As we go throughout again, between the chat function and the exit survey that we complete, if you want to offer more specific areas of training that you feel your agency needs or more specific resources, any type of additional assistance, feel free as we close this out and send you the exit survey to include some of that information in there as well. All right, thank you. We have one more poll. So along those same lines, we know that, every setting is going to have different areas that they feel are the biggest barrier to their site achieving overall compliance. And that's something that both PCG and DMH will be working with all of your settings on throughout this remediation process. But at this point, what do you feel for your site or your agency in particular? What do you perceive as being your biggest barrier to achieving overall compliance with the settings rule? Do you see that as staffing patterns, access to transportation, needing additional education, training, technical assistance, all of these options here, but feel free, please give us what you see as your biggest barrier at this point. We'll give it another 10, 15 seconds. This is really helpful. Thank you guys for responding.
I also believe in the poll you can only see one response, so some people are writing into the chat box if they see more than one barrier on this list that they would want to respond to, so that's helpful as well. Thank you.
Yes, so we will hopefully be able, as we walk through some of these strategies, we'll address some of these things about, ideas for staffing patterns. We know budget and funding is a concern. You hear very often this regulation referred to as an unfunded mandate, so we know it comes, for the state as well, it comes with a lot of work and no additional funding from CMS to ensure that you can achieve compliance. So one of the things that we really like to work for when we think of remediation strategies are things that you can do with your existing resources, how you may just shift some of those staffing patterns without having to hire a bunch of additional staff in order to help achieve some of the things like accessing the community a little bit more often or on an individual basis rather than a group basis. So we will walk through some of those things, and this information will be utilized by us in DMH moving forward too, as I mentioned, as we work through remediation, helping us know some of the additional information or areas that we need to focus on for ongoing technical assistance. So while we've done this series of 4 webinars, this really is only the kickoff to where all of the work will really get started with remediation and working with settings that have been identified for heightened scrutiny, and all of those next steps that we will cover at the end of this as well. So thank you again for your responses. This is very helpful, and we will use that information moving forward. The next thing that we want to cover, so really the foundation for achieving compliance is having strong person-centered practices in place. We know in working with Mississippi that your state is very, I would say, far ahead in terms of working on training. Mississippi's been very supportive of ensuring that settings have access to person-centered planning trainings and understanding the person-centered planning process, but also how to put those practices in place. So this is where we really want to highlight again those foundational beliefs of person-centeredness, because that's where you're going to want to start to structure all of those different characteristics for a home and community-based setting. You have a strong person-centered planning process in place, and working on how to implement that in practice, that's going to help guide you in achieving compliance with every single one of those characteristics. Ensuring that you have those 5 foundational beliefs in place. So making sure you have started with those essential questions. So who is this person? What's important to them? What's important for them? And starting there is really that first essential question that serves as the foundation for ensuring that you are meeting individual needs in each individual that you serve throughout your setting. Person-centeredness is looking to change those common patterns of community life, moving beyond community involvement, and making sure that you're achieving real community engagement and integration. So that way individuals have opportunities to achieve their own personal goals and live the daily life that they want to live. When you're focusing on person-centeredness, you're able to reflect the genuine respect for that individual's dignity, their strengths, and their individuality. So you start to implement practices where you are focusing on each individual rather than looking at the group as a whole and saying, well, everybody needs to do this or everybody needs to go here. Your practices that you have in place really start to reflect that respect that you have for the individuality of each person. You also, when you have those foundational beliefs in place, your site will start to challenge those practices that separate people and start to support each individual to be as independent as possible and have the skills to advocate for themselves. We will walk through when it's appropriate to modify some of those HCBS characteristics. We understand that some individuals will have some restrictions in place, but making sure that those are properly assessed and documented and reviewed on an ongoing basis and not serve to limit or inhibit some of that independence that individuals should have on a daily basis. The other thing that person-centered practices do is require clarity, courage, and commitment to support the individuals that you serve and define and pursue a desirable future. I know we've talked about these more in depth on the last webinar that we had, but really wanted to again emphasize that this is the foundation for moving forward and the practices that you put in place. So, having a strong person-centered planning process is great, but making sure that that's implemented is really the key to achieving compliance in all of those areas. So the next thing that we want to focus on is, you have a person-centered plan in place for each individual. What do you do next? And I think the key to understanding that is that discovering and planning does not stop at that initial person-centered plan. Jamie, can you move the slide forward, please? That is an ongoing process, and those conversations should be occurring much more frequently than just an annual planning process. A lot of the settings and direct staff that we spoke to when we were conducting our site assessments all of these things actually happen on a daily basis. You have a lot of very supportive, direct support staff that take time to know the individuals, understand their needs, understand their goals, and are really having those conversations on a daily basis. They're working with the individuals to know what they like, what they don't like, what's working, what's not working for them, and also recognizing changes in their behavior. So let's say an individual enjoys a certain activity, and all of a sudden one day staff notice that that individual is not engaged in that activity anymore. They seem very disconnected. Those are the things that staff are recognizing on a daily basis. So the key to ensuring that that is that ongoing conversation and communication is that those conversations and occurrences are documented. So again, that planning process can really function on a daily basis, but definitely more often than just an annual planning meeting. And ensuring that, you know, individuals are advocating for themselves and have those opportunities to advocate and feel comfortable enough with their direct staff or whomever they need to speak to. You know, if they have something that isn't working for them anymore or they're unhappy about something, that they have the freedom and flexibility to vocalize that, and that staff are truly listening and then making those changes and documenting those changes accordingly. The other key to implementing person-centered plans is staffing. A lot of the information, you know, we can see from the initial poll that we did, there's a lot of director-level staff and administrative staff on the webinar, which is great. But we want to make sure that there's ongoing training, guidance, and support provided to those direct support staff. So the individuals that are supporting the individuals in your settings on a daily basis have all of the proper training and guidance that they need. They should know about the agency's policies and practices. They should know about the person-centered planning process and how to be engaged in that and ensure the individual and anybody that's important to them is engaged in that process. Sometimes it requires a reassessment of the staffing models. Just throwing staff at people or adding additional staff doesn't always solve some of those program design concerns that don't allow you to properly implement person-centered planning. Sometimes it's just innovative approaches or different ways to think through how you staff and who you staff. The other thing that we will talk about that we did find on some of the sites is ensuring that those direct support staff have access to those person-centered plans. Sometimes those plans were not housed in an individual's home, but housed at the day program. So one of the keys there is really making sure that staff in that residential setting also has access so they can properly support the individual in their home and know what that plan looks like and if there maybe need to be some changes to that plan from a residential standpoint as well. The other thing that your agency can do is making sure that your own policies and procedures are reflective of person-centered practices. I know PCG as a company has taken a really hard look at this. We are all of our staff are trained in person-centered thinking and person-first language, and we are moving toward becoming a person-centered organization. So we want to make sure that we're not just saying these things, but what we do and how we function on a daily basis is reflective of that. And that's another key to your agency being successful and achieving compliance is making sure, just taking a hard look at your own policies and procedures and make sure they truly reflect and support a true person-centered planning process. Any questions so far? I don't see anything come through the chat box, but I want to take a second and give everybody an opportunity. We will start to walk through some of those findings and provide strategies in each one of those characteristics of truly being a home and community-based setting. These findings are generalized from what we found in conducting the site assessments. If you weren't part of the very first webinar that we held, this does reiterate some of those findings. But we completed roughly 260 site assessments of the residential and non-residential programs there in Mississippi. So I'm sure you are familiar with us at this point and have met some of our staff that were there. and worked with us through that site assessment process. So this is a highlight of those findings. And again, we're going to provide some strategies in each one of those areas that hopefully help shed some light on how to start working on remediating some of those areas. And then we will close the gap, as we mentioned earlier, on what's coming next in terms of receiving your assessment report and developing a plan for achieving compliance. So the first area that we're going to focus on is community integration. You will, if you were on the last webinar about achieving community integration, you'll find some of this is a little bit repetitive, but again, the whole key to ensuring that you can achieve compliance is just reinforcing these principles. We did find generally that a lot of settings were taking trips into the community in groups rather than having any opportunities for individuals to access the community. We did hear a lot about limits on independence and individuals being able to do so because of out of safety or concern for the individual. So that all goes back to a strong person-centered planning process and ensuring that individuals that can be more independent have opportunities to do so. Really making sure that you are connecting people to activities or groups within the community where they have an interest or they're seeking membership. And that includes ensuring age-appropriate activities. You know, we know sometimes individuals may choose an activity, whether it's on-site or in the community, that may not seem age-appropriate, but if that is their choice and they were offered many other options, then, you know, that's okay. If they want to, let's say they choose to color. We've definitely interviewed some individuals while we were on site that expressed an interest in coloring. But again, making sure those activities are adapted to what fits their age level. In terms of community engagement, are they interested in cars? Is there a charitable group or a volunteer group at a local hospital or a nursing home that they want to engage with? Do they enjoy flowers or gardening? Is there a local gardening club? So finding out what their interests are and working with your existing resources in the community to help connect them to those activities. We heard a lot about individuals wanting to attend church or participating in various religious organizations. You know, if transportation is a barrier to some of those, you know, working with the church or the local community to see what transportation options are available to help individuals access those. You know, if they're interested, there might be local theater groups that have opportunities beyond just acting in a production. Can they help with painting scenes, posting announcements, selling or taking tickets? All of this starts, really the key to community integration is looking at what you already have in place. Most communities have organizations, they have groups that individuals can be a part of. So starting with really finding out what's already there and working on connecting individuals with those groups. We've seen in other states, there's community advisory boards. So there's local businesses, there's individuals that receive services in their families, or just other individuals that do not receive services as part of these advisory boards that help make some of those connections. Kathy, I don't know if you have anything to add.
Kathy's just having something with the audio. So she's trying to log back in, and she will add it when she can. Have the audio.
No problem. Any questions on community integration? All right. And again, feel free to use the chat function and add any questions as we go along, or you know, if your setting in particular has a certain practice in place that you want to highlight, we can definitely do that as well. So feel free to add any of that information into the chat function.
Looks like Kathy's audio is joined now, so let me see. Kathy, will you try talking?
Hi, Jamie. I'm back on. Thank you. I think we've got it connected now.
Yep, great.
Thank you.
Jamie, if you don't mind flipping back to choice of settings. There we go. All right. So some of the things that we found on site really highlighted across most settings was support staff not being sure of other setting options. We obviously heard a lot about, most of the time, obviously that decision is made at more of a case management level and before an individual chooses a setting, but there should be an ongoing process in place for those conversations to continue. What if an individual decides that they don't like the setting that they're receiving services in, they want to make a choice to move? So it's really key that those direct support staff that have those conversations with the individual know how to facilitate those changes or broader conversations about how to make that happen. And making sure that the conversation includes options in the community. And as I mentioned early on, options that don't just serve individuals with disabilities. If they demonstrate or can have a certain level of independence, can they have their own apartment, and what does that look like for them? In the cases where, they share housemates, they share roommates, there seems to be very limited choice from what we found in the site assessments in terms of how that process works. And we know, most places have a limited number of rooms. You can't always choose, but there should be a process in place for individuals being able to choose their roommates who, their options for choosing roommates who do not have disabilities, making sure that they can take tours and visits ahead of selecting a setting, give them opportunities to meet with their roommates or housemates, as they're touring, and really ensuring the individuals that already live there are involved and engaged in that process. Providing support to individuals to have maybe a night in apartment or alternative setting if they've expressed interest in moving. But it doesn't have to just be a one and done conversation. Individuals should also have a choice in where their meals take place. So whether that's in their room, their bedroom, a private area in the setting, but again, facilitating those choices. I don't know, Kathy, now that your audio's back, if you have anything you want to add to the choice of settings.
I just think it's important to engage in conversation with people about not only where they currently live, but what their dreams might be about where they would like to live.
Yes, thank you. Any questions on choice of setting? All right. Moving on to individual rights, so an overview of the findings that we saw throughout the site assessment process. Some areas of concern were the condition of the homes or the furniture, and just ensuring that individuals have furniture that's not broken or in need of repair and goes on, it stays broken or needs repaired for a lengthy period of time, ensuring that those things are taken care of appropriately. A strong lack of privacy and confidentiality in different areas. So we saw often that medication management was done in a very public setting. Individuals were coming into the dining room or the kitchen area all together and given their medicine all at the same time. Individuals didn't always have opportunities for locked doors, whether it was their bedroom, occasionally their bathroom. There were not a lot of options for storing belongings in a secure place. We would hear that sometimes in the residential settings, we would hear, well, individuals can store their belongings in their bedroom, but then they had a bedroom door that couldn't lock. So again, ensuring that there are options for securing those belongings and not just sitting them in a room where anybody could come and go or take those items as needed. And information on individual rights and filing grievances. We also saw in some settings that employee labor postings were visible in common areas of the home. And again, these really should, we can't emphasize enough that these are an individual's home, so they should really look like that. They should have that appearance. You know, if you have employee labor postings that need to be posted, making sure those are in an area like a staff office that's only accessible by staff and not out in the living room of somebody's home. We do provide some strategies here that will help remediate some of those areas. The key to all of this, from an individual rights standpoint and really anything, as we walk through each of these characteristics, is to ensure that there are no blanket restrictions, meaning that you don't have a policy in place that restricts every individual in the setting from the same thing. For example, you don't have a policy in place that says everybody has to take their medication at 6 p.m. in the kitchen. This goes back to evaluating your own policies and procedures and making sure that you approach them from a true person-centered planning viewpoint rather than, okay, everybody has this diagnosis or everybody has to have this restriction because of safety. All of that should be addressed and managed on an individual basis. And as we've mentioned, any of those modifications have to follow the requirements that are outlined in the regulation. We will walk through those in a few minutes, and be outlined and properly documented in their support plan. Something as simple as I mentioned is removing those employee labor postings from common areas, making sure that they're located in staff offices rather than in those common areas. That's an easy way to make it look, you know, have the look and feel of a home-like setting, rather than, you know, you want to avoid anything that may give the appearance or feel of more of an institution or facility-like setting. Conducting medication management in private. Maybe an individual is comfortable with going into the kitchen and that's where they want their medication administered, but making sure that they have opportunities to do that in private. If they want to go in their bedroom, maybe they can self-administer their own medication, so ensuring they're supported to do that. And again, staff's not always doing that for them if they have that opportunity. But making sure, again, that's a choice. Also, we did see medications, everybody's medications laid out on the kitchen counter. We really want to need to ensure that privacy is secured, so that medication should be locked or put away to where everybody can't see who is on what medication. You know, they do have a right to ensuring that is private, just like you would secure their health information, their medical information, ensuring all of that is in a secure place. Their medication works the same way. Lockable storage space, again, even if maybe you have an individual that has a restriction that cannot have a bedroom door and that has been properly assessed and documented in their plan, still ensuring whether it's a lockbox or a lockable drawer on a nightstand, ensuring that they have opportunities to lock up things that are valuable to them and secure them and not have to rely on staff to hold them or to be told that if it's valuable, they're just not allowed to have it there. The thing to keep in mind is to continue to ask yourself this question, and support staff should really focus on would they want to live there. Again, this is an individual's home. It should look like their home. It should feel like their home, and they should have the same rights as anybody else would in their home. For residential settings, we've seen a lot of times residential settings having a rights council in place. So you have individuals in the setting, their families can participate, staff can participate, but you have a council put together that meets once a month that reviews the agency's policies or gets together to say, hey, we want to engage in this activity, or we see this as a restriction, you know, why is this rule in place? Can we work on this? Keys in particular is one of those things. We saw a lot of blanket restrictions for individuals having access to keys to their bedroom or to their home. And so making sure, again, that that's evaluated on an individual basis. And if one individual has a restriction from having a key, again, that's been assessed, it's been documented in their plan, and that every individual in the setting isn't allowed to have a key just because one person may have that as a documented restriction.
Amanda, this is Kathy. I would just add around the medication administration and management. It's an example where you could work closely with staff on understanding the difference between the balance of important for and important to. So it is important for people to get their medication, but it is also important to people to be treated with respect and dignity. And that might mean receiving your medication in a private place and not with a group of people, so that they have an opportunity to ask staff a question about the medication that they're receiving, or to indicate that maybe they're having some trouble with their medication. Maybe it's really not having the desired effect, or somebody is having an uncomfortable reaction to it, which they might be more limited in providing that information if they're in a group setting. So that's a good place to put those skills into action.
Amanda and Kathy, this is Betty, and I would like to add in the conversation about keys that providers need to document that they have offered the person key, and that they have, if the person turns it down, it needs to be documented and available for the DMH staff to review. Not just staff say, oh, yes, we asked and they didn't want a key.
Yes, thank you, Betty. That's a good point. A lot of this, again, this goes back to those conversations that direct support staff have on a daily basis with individuals. And you very well may have individuals in your setting that say, I don't want one. I don't want a key. I don't want the responsibility of it. It just doesn't matter to me. It's not important to me. Again, if those conversations are happening, just making sure that they're properly documented, as Betty mentioned, so DMH staff also have the opportunity to review that information. All right. I don't see any questions coming in. Again, feel free, even if it's not a question, to share any comments on the findings or strategies that maybe your agency has in place that you feel are very strong and could be utilized by other providers. We would definitely love to hear those. Regarding autonomy and independence, so an overview of the findings, observed some restrictions on access to food, when individuals could access food, and the frequency of which. Often we heard it was based on a particular individual's diagnosis or concerns from a medical standpoint, so it became a blanket restriction across the board. That really goes, again, back to person-centered planning and those blanket restrictions, and making sure that because of one individual properly having a documented restriction, then everybody in the setting is not bound by that same restriction. The choice to remain home. We heard and saw a lot about how if an individual didn't want to access the community or go out with a group, that they couldn't just stay in their home. They may have to go to the home next door because of staffing shortages. So again, things that may require you to evaluate what some of those staffing patterns are, but individuals should have a choice to remain in their own home if they don't want to engage in activities. Visitors and privacy, we did see some restrictions on when visitors can come to the setting, a lot of restrictions on the ability for individuals to have overnight guests, especially in terms of privacy. We saw restrictions on male and female visitors and having opportunities to visit privately, and were having to stay out in common areas or being observed by staff. Also observed a lack of education on choices and options. So individuals having the freedom to choose which church or religious services they attend. We heard most often that occurs as a group and at whatever church is closest to the setting or provides transportation. In our interviews with individuals, we did hear some express that that wasn't the church that they wanted to attend, but they didn't have a choice to attend the church that they chose to. So we'll help kind of work through those things on a remediation, from a remediation standpoint. Also a choice in voting. we heard a lot of sites would encourage individuals to vote, but we didn't hear as much about how sites were supporting individuals to engage in that process. We did hear that one setting had the mayor come in and speak to individuals in the setting about engaging in the voting process, which are all great activities, but those are also things that can be done in the community. So what opportunities do individuals have to participate in election activities or speeches or things going on in their community, actually going out in the community to experience those things with other individuals that live in the broader community, and not just waiting on that information to come to them. We also observed some campus-like settings where all services, supports, activities were done at the same location, maybe not at the home specifically, but there was more of a campus approach to things where you would have residences and buildings surrounding that same area on the same property where individuals would receive all of their services or engage in all of their activities. And there were very limited options for accessing the community outside of that campus. So definitely some things that need some additional focus. Again, goes back to the person-centered planning process. And making sure that people are supported to learn to do things that are important in their daily life, and not just having those tasks done for them. Things such as cooking, menu planning, grocery shopping, preparing their own lunch if they work outside of the setting, doing their laundry, any household task, ensuring that the individuals have that choice to engage and are supported to learn to do those tasks and not just having them done. Those are all important building blocks to independent living. Supporting people to have alone time and to independently access their community by using training techniques. So again, even if an individual has a documented restriction, you should have a process in place that assures that's assessed and evaluated on an ongoing basis. You know, what types of training is being done with that individual, what types of tools are in place, such as shadowing or the use of technology to help support individuals and work toward becoming a little bit more independent. There's a lot of opportunities out there for technology, remote monitoring, check-ins, things that can help support individuals in being more independent on a daily basis. For those campus-like settings, and even if they aren't structured like a campus, still key to making sure that individuals have a choice in who their doctors are, who provides their services and supports, and that they can make those choices out in the broader community. That can be physical therapy, occupational therapy, speech. You know, you may have a setting that has a contract with a certain company that provides those services on site, but what if an individual does not want that provider? You know, making sure that they can access their own physicians or their own hairdressers or churches or whatever the choice may be. But again, all of those services and supports that are in the broader community, individuals should have access and choice in where they engage in those things. Kathy, anything to add there?
No, Amanda, I think you did a good job covering this. I think it really is going back again to think about how best to support people to realize their potential, so that if they have expressed an interest in doing something, we heard a lot of times, I think, where people said they were interested in cooking, but that the cooking was mostly done for them, and there might be an opportunity for the person to learn what goes into preparing a meal, planning that meal, doing the grocery shopping for specific menu items, those kinds of things. It's an opportunity that shouldn't be missed.
Thanks, Kathy. We actually have a couple questions, too, that I want to make sure we address here. A really good question. Can you remove the lock on the individual's bedroom door when you have evidence that they are sneaking a man in the window? I know, Kathy, you have some really good highlights on training and support that can be given to individuals for concerns such as that.
Well, I think that with regard to the question about removing the lock, I think that first off, you would want to engage in a discussion with the individual and talk about the safety processes of having a relationship with a man and making sure that there's no harassment and that there's free choice and knowledge there. I don't think necessarily removing the lock is the answer to that question. Seems like there's something bigger going on if there is not an opportunity for that couple to have privacy in their relationship. So it's hard to give a blanket response, but I would think that you wouldn't go directly from that happening to removing the lock. There would need to be more engagement and conversation with the person to understand what is going on in their life.
Kathy, this is Jennifer. I just wanted to add too, I mean, it depends on that setting and their visitation policies. And so all that would need to be looked at, because if the person feels like they're being restricted in their visitation policies, then maybe that's what they feel their option is. So, I mean, I agree. It's a conversation to see where that person's at and what they're, what they're trying to achieve, and then go from there with education and maybe look into the policies and making sure that person has the access to the visitors when they want, and the education to know what's appropriate and what's not appropriate. And then, I mean, it can lead into many more conversations from there, but it's just a conversation to see where that person is and what they're trying to achieve.
Exactly. I hope that helps address your question. If you have any follow-up, feel free to send that back to the chat box. We also had another question come in about asking for details or a strategy that can be used if a person within the home has a food restriction in place by a medical doctor or registered dietitian, and it was determined by the individual and other members to lock food. Other roommates in the home are not on a restricted diet.
As you said, if that's a medical restriction, then it should be noted in the person's individual support plan, and it would also be noted that it was a choice to have certain food locked so that they would not be able to access it. That would be something that would need to be discussed with the other roommates also, because I'm assuming the food that's being locked away is the food that the person actually is allergic to, but it maybe craves or would want to have. Again, I think it becomes a discussion not only with the person who has the food allergy, but then also with the housemates about how best to make sure that they have access to something that they might desire, but that they understand the importance for the person's health, their roommate, hopefully their friend, someone they care about, to not have that cross-contamination, if you will, of that food. But I think that it becomes something that has to have a discussion in more detail. So it's hard to just give a blanket response that will fit perfectly, not knowing all of the specifics of the case.
I think the other thing I would add to that too is, again, providing that ongoing education and support and working with the individual that has that restriction. You know, if they, let's say it is a food allergy or they're diabetic and they're trying to access foods that can affect their diabetes, making sure that they are properly educated on why they're restricted from those foods, you know, what concerns they have, and working with that moving forward. So again, even though it is a documented restriction currently because of, you know, documented from a medical doctor or dietitian, that you can still work with that individual, educate them on choices, and hopefully work toward not needing to lock the food because that individual has now been properly educated and they know why they can't access that specific type of food.
Absolutely, Amanda. That's a great suggestion, especially working with the person on what would be alternatives to that food that may be the food that they can't have, but what are the healthy options or the things that work for them that they can have access to, and also working toward development of that skill, which we all need to work on, which is sometimes avoiding certain foods for various reasons. And so helping the person understand more globally the impact of that restriction and why it's important for them to start incorporating that into something that's not only important for them, but important to them.
We also had a follow-up, wouldn't we need a statement from a physician regarding food allergies? I would say from a person-centered planning standpoint and a service plan standpoint, absolutely. If an individual has a food allergy, that should be something that's documented in their service plan. I don't know, Betty or Jennifer, if you have anything to add from a DMH standpoint and requirements on those statements.
Yes, we look at history, and then also if there's our physician statements with any restrictions, we also take those.
But family may tell you that, there's a history of food allergy, and if it's documented in the person-centered plan, then that should be sufficient.
Thank you. Really good questions. Please keep those coming as we move forward. We'll go ahead and move forward to choice of services. Here, several of the findings. We did see, even though we know a lot of staff in settings have been engaged in person-centered training, we didn't always find evidence of person-centered planning policies and practices in place. For the support staff and the people that we interviewed as we were touring the settings, definitely saw a lack of understanding in those planning meetings, when they occur, who can be engaged, how individuals can ensure that they are inviting people that are important to them to those meetings. As I mentioned early on, service plans were not always accessible in the home. A lot of times those were housed at the day program rather than being accessible in the home as well. And that kind of goes along in line with the next point about residential and non-residential services being limited to the same provider. So if you are a residential provider and also operate a day program, that the individual had to choose your day program and didn't have options outside of who also provides their residential services, and also being required to attend programs and not having a lot of choice to stay home, or especially in their own home. And really overall just a lack of meaningful choice. And what we mean by that is there was a very limited menu of options, and so individuals could choose to participate or not participate, or they could choose this day program, but there wasn't options given to them outside of saying, okay, you either go or you don't. So really, what does that look like? If an individual doesn't want to engage in something, what other options do they have, and are they just limited to A and B, or are they open for, real choice is not a choice just between one activity or nothing. So making sure in that providing and facilitating real choice that individuals have exposure to the possibilities of all tasks and anything that they can choose from, and having those conversations with them about what that choice should be, and not someone else just choosing for them. We hear this a lot with individuals that have supportive families or families that are in contact. There is a difference between an individual having a family member that's engaged versus an individual having a legal guardian in place. Obviously, if an individual has a legal guardian, that person should definitely be part of the discussion and helping facilitate some of those choices and options. You definitely don't want to ever be dismissive of families and their opinion, but making sure that if an individual does not have a legal guardian in place or that family member is not their legal guardian, that that person is really driving what their choices are and not somebody driving that choice for them. Some of those strategies to help with that is training the direct support staff on that planning process. And again, it goes just beyond having a plan in place, but what can be done on a daily basis to ensure that things in an individual's plan are actually reflected in their choices on a day-to-day basis. Supporting them to be self-advocates. Again, if they don't have a legal guardian in place, they really should be driving their choices, services, supports, activities, food, anything that you and I would have a choice in on a daily basis. They should have opportunities and feel comfortable to advocate for themselves in making those choices. Investing time in pre-planning and the discovery process, really getting to know who that individual is and what their goals are. We've talked about this on a previous webinar, but this really is also touched on early on in this one, those ongoing conversations that support staff are having with individuals. A lot of this is already there and it's happening. It's just a matter of properly documenting it and helping ensure support staff have the right resources and training and education to make sure that that's implemented on a daily basis. Assisting people to have exploratory experiences with different types of work. If an individual wants to volunteer somewhere or engage in a certain type of employment, that they should have opportunities to really explore that and make sure that's what they want, and have those opportunities and not just be forced into specific types of work or specific types of activities. We touched on this also, but making sure people are supported to visit other types of residential settings, and that includes settings that do not just serve individuals with disabilities. If they express an interest in really wanting to change their services or where they live, given the opportunity to tour, maybe stay for a night, or really see and explore if that's the type of choice that they want to make, and have, again, the encouragement and the support to be able to evaluate those options. Kathy, anything to add there?
Yeah, I would just like to add that I think this is an opportunity when you're talking about choice, and the example that Amanda used when families may speak on behalf of the person or make strong recommendations that may or may not be the choice of the person. I think this is where it's an opportunity. I know that direct support professionals don't often have the opportunity, or at least all of the staff from a home or a day program may not attend the service planning meetings. So this is where it's important for the staff that are attending the meetings to spend time with those staff also and get input and gather information. It may be an opportunity where the staff can then express that the person has expressed to them a preference to do something that is new or different than what has been brought up in the past. And so making sure that the direct support professionals have an opportunity to at least have information from their experiences with the person brought to the meeting for discussion. I think that that's really an important aspect that is often missed. And so while we talk about investing time in pre-planning and getting to know the person, it's also important for the staff who are working daily in close contact with the person to have input into that planning process too, based on their knowledge and experiences with the person.
Thank you, Kathy. I don't see any questions in the chat box. We will move on to physical accessibility, but again, if you have any questions, concerns, comments, strategies, feel free to drop those in the chat function as we move forward. Physical accessibility, so a few areas that we did have some findings on. One was limited bathrooms, so there would be bathrooms in the setting that were only accessible to staff. And so, those are one of the things that we want to mitigate moving forward, and making sure that, you know, if an individual needs to use the restroom, they should be able to utilize any restroom throughout the setting. Accessibility to use doors or move throughout the site. We would see a few areas there where individuals would be restricted from a certain area of the home for whatever reason. We often saw sometimes that was related to gender, so males would have to be on one side, females would have to be on the other, and they could not access the other side of the home. So any type of unnecessary restriction like that in place. And back to the question provided earlier, you know, if there are questions about male and female interactions and having concerns for safety or whatever the reason would be, making sure that individuals are trained and educated on those things and not just restricted from engaging with other individuals in the setting. We would also see restrictions or barriers to accessing the outside, so individuals couldn't just walk outside of the front porch or the back porch. They always had to be directly supervised or within eyesight of staff. Again, that can be an unnecessary restriction for an individual if they don't have, you know, a documented restriction or of wandering behaviors or something like that. So for people that have limited mobility for any reason, you should be able to ensure that they can move freely throughout their home or their day setting and access all common areas that anybody without limited mobility can access. For safety reasons, this should mean that people have at least 2 options for egress, just in case one of those options is blocked. One of the things that we would see occasionally, I think in the reports, there's going to be a lot of questions about fences. Generally, fences around a setting are okay so long as they're not in place to specifically serve as a barrier or intended to restrict individual movement. So if it's a privacy fence, just like any other home would have, you know, that's often very common and shouldn't be as an issue. But if they have specific locks or latches that are not functional or accessible to individuals in the home, or they can't operate those, then that can serve as an unintended barrier. So those are the things that you want to take a look at, and you know, you'll see some information on as you start to receive your site reports, if there were any concerns about the type of locks or gates that were in place. Same thing with security codes to doors or secured fences. If there's a passcode to operate any of that, do individuals in the setting have access to that code? Do they know how to operate those things? So again, making sure that you don't have something in place that, even if it's unintended, is serving as a barrier to restrict individuals from accessing any particular area of the setting. Kathy, anything to add there? I don't see anything in the chat box.
No, I don't have anything, Amanda. Thank you.
Thank you. All right. We will move on to modifications. So this is something that we've covered previously about person-centered planning. And, you know, we've talked a lot about properly documenting restrictions. But the final rule states very clearly that any time any of those characteristics of an HCBS setting are modified, that it must be properly assessed and documented through the person-centered planning process. So these requirements listed here are all reflected in the final rule and what should be in place and very clearly documented in that person-centered plan if there is a modification or restriction in place. Again, it should be driven by that individual. They should understand why there is a modification to their plan, why they can't access food, or why they can't access certain areas of the home, whatever the modification may be. That modification should include all of the necessary information to support the individual and ensure that the individual directs that process. It should be written in a way that is very clearly understood to the individual, taking into account any sort of cultural considerations. Should also have a process in place and include strategies for resolving disagreements. So what if an individual doesn't agree with a certain modification? How do they go about resolving that disagreement? Who do they speak to? What is the process in place for evaluating that? Also ensuring that there are choices for the individual to choose their services and supports, who they receive those from and whom. There is a method in place to request updates. So let's say there's a modification in place and the individual comes to support staff 6 months later and expresses that they feel that that modification is no longer appropriate and they want to remove that, or they want to update their services that they receive. How do they go about doing that? Who do they speak to, and how do they ensure that that is properly reviewed and ultimately reflected in their plan? And again, all of those, that planning process just in general should reflect what the individual strengths, preferences, needs, and desired outcomes are. Anytime there's a modification, there should also be an ongoing review. So data should be collected. There should be proper documentation that other least restrictive measures have been tried before that modification was put in place. And knowing that once that's in place, it doesn't stay in place for the duration of that individual receiving services in that setting. It can be very likely that a modification would be short-term in the example of the individual being restricted to food because of a certain medical condition. If they receive proper education on an ongoing basis and they learn what they can eat and what they should eat, and they no longer feel like they have to access certain foods that may not be beneficial to their health, that's a modification that could ultimately be removed from the planning process. The modification should also include informed consent and be signed by the individual. So you should never have a modification in place that has not been reviewed with the individual, discussed with them, and ultimately signed off on, as in they understand why the restriction is in place. Kathy, anything you want to add to modifications?
No, Amanda, I think you've covered it very clearly.
All right, and I don't see any other questions in the chat box. Before I move on to next steps, I don't know, Betty, Jennifer, do you have anything that you want to add?
This is Betty, and as we were reviewing this, let me say that we need all providers to take a look and maybe begin reviewing the person-centered plans of the persons in their homes, and if there are modifications required, someone is restricted, that you make sure that is a part of that person-centered plan. There needs to be good communication between the providers, the direct support staff, and support coordinators, targeted case managers, that you're talking with each other, that you are making sure this information is in that person-centered plan. So there may need to be some revisions as part of your strategies to become compliant.
Very helpful. And as we move into these next steps, we'll talk a little bit about that ongoing process and just ensuring that this is not the end of the conversation. This really is meant to serve as the beginning. And once you all receive your reports and start to work through that remediation process, that there will be ongoing guidance and technical assistance provided that helps. If you start looking at those person-centered plans and you have questions about how to properly document a modification or what that should look like, there will be support provided for those things. So we'll move on to next steps. And this part especially, we're going to let you know these are immediate next steps. So this is where we are and where we're going to be working toward very quickly. So if you have any questions as we walk through this, again, please feel free to drop it in the chat box or make sure that you provide comments in that exit survey once we get to that point. One of the immediate next steps is you're going to receive your a report of the site assessment that was conducted, and along with that will be a compliance recommendation. That recommendation falls into one of 4 categories. So once we finished assessing settings, we provided a recommendation to DMH, and DMH has reviewed those. And the compliance determination either include fully compliant, so already fully aligns with all of those characteristics of an HCBS setting. The second bucket, so to speak, is that you may not currently comply, but you can with modifications. So we will work with you through that remediation process, and that is a very clear indication that, you develop remediation strategies and put some things in place. You absolutely can become compliant with all of those characteristics of an HCBS setting. The third bucket is cannot meet federal regulations. I will tell you we did not encounter any settings like that. And both our goal and DMH's goal is to work with everybody to ensure that they can become compliant with the final rule in plenty of time to ensure that you are compliant and able to continue to receive HCBS funding for the services that you provide to individuals. The fourth bucket is heightened scrutiny. So this is where the state must provide evidence that your setting is not institutional or isolating and does in fact meet or can meet all of the characteristics of an HCBS setting with, remediation. We'll touch on heightened scrutiny more in depth in just a few minutes, but I have a couple questions coming in. There's one question, Betty, I'll turn this over to you. How long before they will receive their report with their compliance determination?
So we're compiling that information now, and those reports will go out in July and August. We are staggering those reports because there's only a few of us here at DMH to review your responses, and there's a timeline associated. So if we send them all out at once, we'll get all the responses back at once. So we are staggering those. So you should receive those in July and August. And also, I wanted to point out on the heightened scrutiny category 4, it says that it requires CMS approval. If that heightened scrutiny isn't the category of being in or adjacent to institutional setting, and you come into compliance before July 1 of 2020, then we do not have to submit all the information to CMS, just a portion of. So we just want to let you know that as well. So there is an incentive to come into compliance and to come in compliance quickly, because then your agency or that site will not be reported to CMS.
Yep, very important to highlight. So the state, as part of that heightened scrutiny process, will have to post a list of settings that were identified for heightened scrutiny. But as Jennifer pointed out, if the setting is remediated by July 1st, then the state does not have to go through the process of putting together a full packet and actually submitting all of that information to CMS. So as we start working through that heightened scrutiny process, there will be some additional information forthcoming on that. Another really important question that came through, will there be any education offered to families regarding the final rule? Since the onset of these trainings, we have had a mother pull her daughter from our residential services because of our position that we would not restrict her visitors unless there was a true safety issue. As a provider, it would be helpful if support coordinators can take a position to support the provider who is attempting to be consistent with the final rule.
This is Jennifer again. So yes, support coordinators will continue to receive training on the final rule and support providers in that effort to be compliant. And families can also be educated as well. And so we're kind of thinking through some options there on how to get that information out to families, whether it's some documents or just supplying everybody with frequently asked questions. That way they can talk through these issues with families, or if maybe that's a webinar if we see that it's an ongoing issue. So we we can take your feedback anytime and would welcome it if you see any issues that are not being addressed.
Thank you. Really good questions. So once you receive your site report with your compliance determination, the next step is working through the remediation process. So this process that's outlined on the next slide is reflective of the process that the state developed and highlighted in their statewide transition plan that's been submitted to CMS and has been out there for public review and comment. But the immediate next step is for BIDD to send that site report with your compliance determination. So you will receive that, and then you will return your report with some specific remedial strategies that have been outlined. The next few slides will give you an overview of what that report looks like, so what you can expect to complete. When BIDD receives that, they'll review it, make a determination to accept that plan, and then work with you to ensure that what you put in that plan is actually put into place, and just guide you again through making sure that every setting has an opportunity to come into compliance, and then there will be subsequent state review once that plan has been put into place. Jennifer, I don't know if you have anything you want to add to that process at this time.
Are there any questions?
No, are there any questions regarding that process?
Nothing that's come through.
Okay.
All right, so the next couple slides are an example of what your provider compliance report will look like. Your first cover page just will list what your name is, ID, address. We ask for the name of the individual that's completing your report and their title. That way, when there's follow-up questions, the state knows who to work with on making sure that that plan is reviewed and properly approved, and they can get those updates as needed. There is an instruction section, so the next area of that report gives you an overview of those different characteristics. It points specifically back to the language in the federal regulation. So, Jamie, if you could flip to that next slide, you're going to see this is a very broad. It kind of wraps up all of those questions from the site assessment report and speaks generally to each one of those characteristics. So the first one is about access and integration into the broader community, and you'll see a very quick highlight of whether you were compliant with that section, partially compliant, or not compliant at all. And that wrap-up is all based on those site assessment questions, so this will align with your site assessment report that you received. So we walk through each one of those areas, and then once we've covered that, your next several pages of your compliance report will include the opportunity for you to, it'll list the areas where you were not compliant or need some remediation. So for example, one of the first choices about being able to make informed choices related to home, work, services, relationships, recreational activities, et cetera. You'll have the indicator as to whether you met compliance with that question or not. And if not, we will ask you to outline some strategies for remediating that. So in this example, one strategy would be to implement quarterly meetings with each individual to discuss services, activities, relationship, making sure that you're updating the individual rights policies to include information that's reflective of some of those person-centered practices, providing training to the individuals regarding any changes to that rights policy. Very specific tasks that are outcome-oriented, and the state can actually go back in and verify whether those strategies were actually put into place and help remediate whatever area of concern is highlighted. The other pieces that would be required is setting a time frame or a target date for completing those activities. You would indicate an individual that would be responsible. That can be obviously by title because we know there's turnover, but who in the setting would be responsible for ensuring those activities are put into place. And then the opportunity for some ongoing status updates. And then when that work has been finalized, you would include a completion date. The example that's shown here on the screen will be included in the report, so that's just set to serve as a guide for you. The other thing in the report are some potential strategies that you can put in place. We want to make sure as you're completing this report that you're not just regurgitating the strategies that we provide as potential examples, but are really developing things that you know will work for your setting and your agency and the individuals that you serve, rather than just restating ideas that we threw out there. So making sure that they're very specific and outcome-based, and can be put into place in the appropriate time frame to make sure that you are working toward achieving compliance. We do have a question come through actually about voting. So individuals who need or want to vote, could vote, have an opportunity to vote ballot prior to the day of voting so that they could avoid long lines and have opportunities to vote. I think the question's getting along the lines of absentee ballots. Of course, that's, if that is what the setting is helping facilitate and support individuals to do, it doesn't mean that you have to properly transport everybody the day of an election to encourage them to vote. Maybe if an individual has a restriction or can't just access the community or doesn't want to go out and wait for 2, 3, 4 hours in a voting line, making sure they're educated and giving those opportunities to vote prior to, that's absolutely appropriate. I don't know, Kathy, if you have anything that you want to add there.
Yeah, I would agree. I would think that it would be something that would be individually decided. If a person doesn't have a tolerance for lines or wait, as Amanda referenced, that would be one thing. The other thing would be if the person would prefer to go vote on election day, but the staff don't have the time, especially if it's a heavy turnout or that kind of thing. There are volunteer groups who will transport and support people through the voting process. So again, an individualized solution to that situation would need to be explored.
This is Jennifer again. I just want to echo what Kathy and Amanda are saying. It's all about individual choice, and that the person has the access to the community that anyone else does. So if it's based on their choice, then they're right. But we shouldn't be restricting people based on our staffing issues, and because it's not convenient for us to do something.
Actually, a really good point that leads me into the next part of the conversation on heightened scrutiny. If you have questions about this provider compliance report, feel free to drop them in. I can backtrack at any point if you have questions. But that's what you can expect to see with your site assessment report as it comes through. Regarding heightened scrutiny, there will be some settings that fall into this heightened scrutiny category. And the important thing to remember here is there is a very strong distinction between settings that are subject to heightened scrutiny versus settings that are not compliant. Heightened scrutiny, despite the terminology, is actually a very positive process, and it is the state attesting that the setting can become compliant with all of those characteristics through the remediation process. If you, again, we didn't have any of these settings, but if you were to have received a determination that said you're not compliant, that just means no matter what you did, no matter what strategies you put in place, there was no possible way to come into compliance with the HCBS final rule. That is not what heightened scrutiny is or tries to get at by any means. It is just by the fact of design or the way the setting is structured, it fell into one of these 3 buckets. So CMS sometimes refers to these as prongs, but essentially there's 3 different prongs to heightened scrutiny. The first is a setting that's located in a building that's also publicly or privately operated that provides inpatient institutional treatment. So essentially within these first 2 prongs, if it's located adjacent to a setting that is in an institution or provides that inpatient treatment, so a hospital, a skilled nursing facility, an institution for mental disease, or an intermediate care facility, those are some of the settings that would have some potential concerns and fall under that heightened scrutiny bucket. The third, which has been a little bit more subjective, CMS just released guidance in March along these lines, but the third prong to heightened scrutiny is settings that have the effect of isolating individuals from receiving home and community-based services from the broader community of individuals that do not receive Medicaid HCBS. So that recent guidance from CMS has provided a little bit more clarity here. And it really, the thing to remember here is it's not solely about physical or geographical location. While physically located separate and apart from the broader community is a component of it, it really hinges on the facilitation of individual opportunities to access that broader community. It looks at the design or model of service provision. So if any of those things in place, or there's restrictions on individual choice to receive services in the broader community, if individuals have very limited access or aren't provided opportunities to access the broader community, that's really when that setting can appear to be isolating. It's not just about being located in a rural or more remote location. Heightened scrutiny and falling into that third prong. No setting that is rural or remote fell into that category unless they demonstrated some of those other concerns about program design, service provision, and restricting individual choice and movement. So this does not by any means mean that a setting would have to physically relocate just because they're in a rural area. It really is going to focus on that service provision. How are your staffing models in place? Are your staffing models or the way you provide services and supports restricting those individual choices and that individual access to the broader community? Have you taken a look at what those community resources are and utilizing what's already in place? Some of those things that we talked about on that very first slide in one of the last webinars about how to really achieve community integration. So it's going to be focusing on those things and working through some of those barriers and restrictions, even if they are unintended, but working through those things to make sure that you're not inadvertently isolating individuals from the broader community. So please keep in mind that if your setting fell into this third prong, that again, it's not a determination that you're not compliant. It just means that we're going to have to work through that remediation process and focus on that design and service provision and remediate those areas so you can become compliant. But again, it does mean that as you work through remediation, you can achieve compliance with the final rule. We don't want to see any settings shut down or close or individuals choosing to pull their family members out of services for fear that they can't continue to attend services there. All of those things can be worked on, and you can develop strategies through that remediation process to make sure those things don't continue. Jennifer, I know we've talked about this in particular, but I don't know if there's anything else you want to cover there under heightened scrutiny.
No, I just want to add that we feel like that everybody can come into compliance with the final rule and that we're here to help and work through those issues with you, and that we're looking forward to seeing what providers come up with as their strategies to reach that compliance, and that we're here to work through that process. So we feel like that everybody can come to compliance, and we just want you guys to know that.
Let me add, too, that the large majority of our settings fall into the category that they just need modifications. So we think that just some minor things that you can do to come into compliance will be done. But we do have some in heightened scrutiny. We have a very few settings that fall into this second prong that are located adjacent to a hospital or an ICL. So you providers, you know your settings, and so you know that those in particular will be in heightened scrutiny. And those must be submitted to CMS. But if you're in the third prong, which most of those that have been determined in heightened scrutiny fall into that third prong, it's because of your design or your model of service provision. If you become compliant by July 1st of 2020, then we have the opportunity to take you out of heightened scrutiny, and it would not be submitted to CMS.
Thank you. I think that's a really good point that Betty brought up. So one thing that, even though you don't really have to wait until July or August to get your site report to really start thinking through some of these things and looking at your setting now. Hopefully through this series of webinars, we've given you enough information that you kind of know where to start to look, again, even before you receive that report. So look at your person-centered planning process. If you know you're located adjacent to an IMD, what are the things that you can start thinking through now in terms of how your services are provided or how your program is designed, that you can start thinking through some potential strategies and already working through that process, working with your support staff and starting to identify some of those areas that may be of a concern when you get your site report. So, those conversations don't have to wait until July or August to start, but you can start really taking a hard look at some of those policies and practices now. And, feel free to share. Again, this isn't always just about not currently being compliant, but there's going to be areas that are highlighted in all of your reports where you already are compliant. You're already doing things well. So thinking about how you can further develop those strategies or continue those moving forward and possibly share those through, to other providers or other resources and helping others through that process. We would definitely love to hear anything that you have in place that you feel would be beneficial to providers as a whole. I don't see any more questions coming in. We have a couple more slides to cover, but we're wrapping up pretty quickly. So again, if you think of anything that you want to ask or share, feel free to go ahead and drop that in the chat box. Moving forward, so again, just reiterating some of those immediate next steps. You're going to receive your site assessment and compliance report. DMH will be working with all of the providers to provide ongoing technical assistance. So some of those barriers and things that we identified early on, there will be continued information and guidance. As Jennifer mentioned, it could be in the form of FAQs, but there will be more training and information that comes forward. Jennifer, I don't know if you have anything in particular that you also want to touch on there before we wrap up.
No, not really. Just to reiterate the point that we are here to work through these issues with you guys, so feel free to reach out and talk to us.
Thank you. Take a little bit to pause to see if you have any questions. But again, just want to reiterate that we are all here as a resource. Everybody's goal is to ensure that every setting can achieve compliance. We by no means want to disrupt services or supports to individuals and want to provide the level of support and assistance that every setting needs to be able to develop those remediation strategies and come into compliance. We also, so the series of webinars have been recorded. They will be posted. Feel free to go back and access those and share those with any of your staff that maybe couldn't attend the webinars, but utilize those for some ongoing information. And as you think of any other questions or things that may come up throughout this process, please make sure that you share those and submit those so we can make sure that we're properly targeting that ongoing training and technical assistance. Any questions?
If you would, when you're sending those questions in, just remember that we are keeping track of those frequently asked questions, and we're compiling a document. So if you have questions, likely someone else does as well. So don't hesitate. Send those in. You can send them in through the survey at the end of this webinar, or you can email either Betty or myself or PCG. So you have options there to submit those questions. So feel free to do that.
All right. I'm not seeing anything come through. Jamie, do you mind? So we do have an exit survey. Jamie's going to drop the link to that survey in the chat box. Please, even though this was the last webinar of this series, please complete that exit survey, provide us any feedback If there are other areas that you want to see some additional information, please make sure that you share that as part of that exit survey. We would love to hear any feedback or additional information that you have. So again, that survey link is in the chat function. When this presentation is posted, and I know I sent it to people who had pre-registered, but you will be able to access that link at any point. So please feel free to take the time, complete that survey, and share any information that you would like. And then just the last slide gives you Jennifer and Betty's contact information. So again, as they mentioned, we can't reiterate enough, feel free to send any questions or follow-up information to them. We are tracking all of this information. We will be posting FAQs and want to make sure that we are always providing you with all of the information and resources you need to become compliant. We really appreciate the time that you all have taken to participate in these webinars, not just listen, but to send in questions, to participate in the polls. We greatly appreciate your participation and really look forward to working with you throughout this process. Jennifer, Betty, anything else to wrap up?
No, we're good here. Thank you guys for joining.
All right, thank you all so much. Again, please complete that exit survey, and all of this information in the webinar will be posted. Thank you.